Hi guys, my name is Alexa Christensen, and this is the neonatal modes of ventilation talk. Here are our objectives. I have no disclosures except for these two cute kids of mine. Okay, so I do apologize that this is not live in person, but I would suggest if anybody has questions as we're going through this, and you probably will, which is just fine, go ahead and just jot those down, and if you can find me or another respiratory therapist that you're working with, we'd be happy to answer any questions that you may have that come up. Okay, here's kind of what we're going to go over today. Starting with fetal lung development, to kind of understand the different modes of ventilation and the different things that we're going to do with these kiddos, we kind of have to start at the beginning, start at the basics. So the saccular stage is between 24 and 36 weeks. That's where the alveolar ducts and air sacs are actually developed. Before this time, before this saccular stage, 24 weeks, fetal lungs actually cannot support adequate gas exchange. They just simply have insufficient alveolar surface area, and their pulmonary vasculature is completely inadequate. So that's where we see, obviously, a lot of our kiddos here in the NICU born around that 23, 24 week stage. And so they literally just cannot survive because they do not have the vasculature before that, if they are born before that. And that's why viability is that 23, 24 week stage. We can kind of see between the saccular and alveolar stage. The alveolar stage is where the alveoli just continue to grow, duplicate in number. We can kind of see in between these two stages is where that magical substance that we know as surfactant begins to come into play. This is important because anything before kind of these stages where there is no surfactant, these kiddos are already at quite a disadvantage because of their prematurity age, and then not having the surfactant just puts them at even more of a disadvantage with the disturbances that we're going to cause. Disturbances within these two phases here, and when I say disturbances, I mean just being born prematurely, being put on the ventilator, high FiO2. Disturbances in these phases can really lead to the formation of lungs with fewer alveoli and a dysmorphic pulmonary vasculature. So we talked about when the alveoli are formed, what stage, and how premature alveoli, kind of looks. This slide just shows kind of the number of alveoli based on gestational age. So as you can see in these pictures, a 35-weeker, even to 36 weeks and beyond, has a significant difference in the number of alveoli that baby is going to have. So alveoli are present in infants as early as 32 weeks. However, they are not uniformly present until 36 weeks of gestation. Surfactant deficiency. This is going to be the biggest characteristic of RDS and premature lungs. Like I said, they begin to produce surfactant between the ages of 24 and 28 weeks. Surfactant, if you are surfactant deficient, the tension or the surface tension of your underdeveloped alveoli is actually high. So if the tension of something is high, that means that we have an increased chance of it rupturing or popping or just being inadequate as far as to produce gas exchange. Surfactant is made up of some phospholipids and proteins, and it feels like a viscous liquid, kind of like a dish soap. So when you're given surfactant, it decreases that surface tension of the alveoli, which then promotes good oxygenation and better blood flow between the alveoli and gas exchange. Kind of a little tidbit, an interesting tidbit about surfactant production. if you've ever heard of, we're going to get a baby, 28-weeker, mom had her steroids. Why is that important? Basically, once mom has finished her steroids, and when it gets to so she's still pregnant and she's been given those doses of steroids, once they get to therapeutic levels, so she's completed her course, giving steroids to mom actually stimulates the synthesis and release of surfactant into the alveolar spaces. So we really want to make sure, if possible, that mom has finished those courses of steroids before delivery. One more interesting tidbit about surfactant is these kiddos that are born to diabetic moms. So we know by 35 weeks the body should produce enough surfactant to keep those alveoli open, but one exception to this is IDM kids. Hyperinsulinemia, so maybe a mom that did not have very good controlled blood sugars, hyperinsulinemia actually suppresses this production of surfactant. So these big IDM kids that look like they should be fine, they're good weight, 35-weeker that weigh 7 or 8 pounds, end up needing respiratory support. It's because they are actually surfactant deficient. What are these kids going to look like? I think we've all seen kids that are in respiratory distress, surfactant deficiency, kind of having all these clinical characteristics. Complications of premature lung disease, RDS, all these terrible, terrible things. BPD, if you've never heard of that, bronchopulmonary dysplasia, it's kind of the end result after a baby is, a few months old of having severe premature lungs. And then we are going to talk a little bit about PIE. Alveolar rupture is what ultimately leads to PIE, and there's lots of complications from that. Okay, what is PIE? When that surface tension of the alveoli is very high, so maybe the baby has received surfactant or maybe they have not, and there end up being tiny ruptures in the alveolar sacs. This results in air getting trapped in the tissue outside of the air sacs, but in the lungs. That air actually becomes dead space, or air that just sits there and does not participate in adequate gas exchange. Any air that sits there that does not participate in gas exchange is useless and increases pressure in the lungs, and it's very difficult to get that dead space or that air out, and it just ends up being very, very bad for the baby and can cause long-term damage. So here's kind of a picture of an alveolar sac, and then if there was a little tear and air got trapped in between the alveolar sac and the where blood flow needs to happen between the blood vessel. PIE is prevalent in ventilated, extremely low birth weight or micropreemies in the first 72 hours. It's very difficult, as much as we try, it's very difficult to prevent it because of the fragility of their lungs and premature alveoli. With appropriate ventilation, it can actually resolve. Those tiny holes in the air sacs can close, and it can resolve over a few weeks' time, and we'll talk about that here in just a second. This is also an X-ray of what PIE kind of looks like. It kind of looks like crushed up ground glass. Okay, so we are going to talk about all these modes of ventilation, starting with the oscillator and ending with CPAP. Before we go over the specific types of ventilation, here is some ventilator terminology of what do all these things mean. These are all the things that we can set on the various ventilators or things that can be measured. And I'm just going to go over each one kind of real briefly because I do have a definition there. But your PIP, or your peak inspiratory pressure, is the highest level of pressure that exists during inspiration. So when you and I take a big deep breath, if we were to hold it And if somebody would drop a pressure manometer down into our lungs and measure the amount of pressure it took to get that big, deep breath, that's your PIP. So it's the pressure that is measured by your breath on inspiration. Tidal volume is very similar to PIP, only now we're going to measure the amount of air that's in our lungs in mils. So if we take a big deep breath and we were able to measure how many mils of air are in our lungs, that is our tidal volume. And that can be measured, you can have inhaled tidal volume or exhaled tidal volume. PEEP is the pressure in our lungs at expiration. We all have PEEP in us on exhalation. None of us exhale all of our air out. So same thing, if we exhaled as much air out as we could and we measured the pressure in our lungs on expiration, we might all have a PEEP of 3, 2, 3, 4 in us. PEEP is what's going to control our oxygenation. Rate, how many times a breath, how many times a minute are we given or are we breathing? Inspiratory time, the time it takes to deliver the inspiratory part of the breath. Pressure support is a supportive inspiratory pressure that assists the patient's spontaneous breaths only. And I'm going to explain this in more detail, but pressure support is a setting that is just assists in the patient's spontaneous breaths, not the ventilator breaths. What is MAP, mean airway pressure? It is an average constant pressure in the lungs during ventilation. We're going to talk about that a lot with the oscillator and the jet. Delta P is just the difference between two measured pressure values. So for example, a delta P is like the difference between your PIP and your PEEP. You have a high pressure and you have a low pressure. What is that number in between? That is the definition of a delta P. Hertz is how fast we're going to give a breath on the oscillator. It's actually equivalent to 1 breath per second, not a breath per minute is what we're going to measure a rate, like on a regular conventional ventilator. And the servo is not really a setting, but it's a measurement on the jet. It just tells us kind of how much flow is running through the jet and tells us that things are kind of working properly on the jet. Okay, so first we're going to talk about the oscillator, high frequency oscillator ventilator. The oscillator is considered an unconventional. So conventional means that you breathe, conventional is breathing just how you and I are breathing, inhale, exhale. Unconventional is just a different form of breathing. Lung protective form of mechanical ventilation, introduced in the 70s. Primarily used for neonates, but it can be used in the PICU and in the adult ICU. Minimizes cyclic stretch volute trauma. What does that mean? Pushing a breath into the lungs over and over, conventional breathing, the way you and I breathe. To do that with premature lungs is what can cause lung damage or volute trauma. So the oscillator is going to inflate the lungs. So if you've imagine taking a balloon and you're blowing a balloon up slowly to a certain pressure. And when you get to that pressure, you're just gonna shake it or vibrate it or have little bitty inhale, exhale breaths outside of that. So oscillator is essentially a vibrating CPAP machine. And we'll talk about what CPAP is at the end, and that'll kind of make a little bit more sense. So the oscillator is gonna open up the lungs to a certain degree, certain pressure, and then basically shake it. How does the oscillator work? Super tiny tidal volumes, 1 to 4 mils per kilogram, but they're not measurable. Delivered at very, very high frequencies. It uses an oscillatory pump. The oscillator works with both active inhalation and exhalation. The oscillator tubing is going to push that breath into those babies and actively pull that breath out. And we'll talk about that a little bit more with the jet, why that's different and important or not important. The goal of the oscillator is to maintain lung recruitment and to hopefully prevent lung injury from over-distension. So we want to recruit those tiny alveoli, open them up, keep them open, and prevent them from popping. Okay, so just a little slide here to kind of show the oscillator compared to a conventional ventilator. The first thing I want to do is show you, talk about these pink screens up here. A and B, CMV, this is conventional mechanical ventilation. This is just the regular inhale, exhale like you and I breathe, and like the Avia and Draeger ventilators that I'll talk about. This is actually alveoli under a microscope. So this is alveoli in inspiration of premature lungs and alveoli on expiration. They literally have disappeared. On the oscillator, here is inspiration and expiration. They look exactly the same. This is a really important quote. It is much harder to open the alveoli than to just keep them open. So if we can keep them open, that is the best way to ventilate and oxygenate these kids versus if you've let them collapse or close, trying to get them back open. This little graph right here just kind of shows you some of the settings and measurements of conventional ventilation versus the oscillator. So these big waves here, this is regular breathing, conventional ventilator. This baby is on the Avia or the Draeger. So inhale, exhale, inhale, exhale. When this baby exhales down here to a PEEP of 10, this is what's happening right here. The alveoli are kind of coming down, maybe disappearing, collapsing all the way. This kind of crazy wave in the middle, these are oscillator breaths. So here you can see we have a constant mean pressure, constant recruitment. Those alveoli never have the opportunity to close. So we have increased gas exchange, increased alveolar recruitment. When are we going to use the oscillator? I will tell you, before we purchased the jet in the last few months, all of our extreme prematurity micropreemies went straight. Most of them went straight to the oscillator. It was classically the most lung protective form of ventilation that we could use for our babies. However, now the plan will be to start with the jet, and I will talk about that. But the oscillator is a great machine. It's been around for a really, really long time, and we will continue to use it here. We just are going to tweak a little bit how we use it. So indications for use: extreme VQ mismatch. What does that mean? Your patient is ventilating. Their CO2 is okay, but they're not oxygenating. They're on 100%. Gases are terrible. They're only statting in the 60s and 70s because of whatever is going on that they cannot oxygenate. Or maybe they're oxygenating okay. They're only requiring 50% oxygen, but we have done everything under the sun and we cannot get our blood gases, our CO2 to come down on conventional ventilation. We're going to switch that patient to the oscillator. So extreme VQ mismatch or unmanageable blood gases. Any patient who needs ventilated with higher pressures or higher mean airway pressures, like a high drops baby, congenital diaphragmatic hernia, anything that's going to put pressure on the lungs where these babies need kind of a stronger, higher pressure machine, the oscillator can do that. PPHN, excuse me, and then extreme prematurity when the jet's not available. Here's what the oscillator looks like. We have basically 3 settings that are going to change, and then we have our FiO2. Here is our mean airway pressure, our MAP. That's what's going to control oxygenation. That is the average, remember that's the average constant pressure that's maintained in the lungs, controls alveolar recruitment, oxygenation. Initial setting, we're going to go 10 to 12, or 1 to 2 higher than what their MAP was running on the conventional. We'll increase it in increments of 1 until we get that baby oxygenating where we want him to be. Delta P, remember that's kind of the change in pressure. If you have two different pressures and what is the change in pressure in between. So once we get those lungs expanded to a certain mean airway pressure, the itty bitty tiny inhale, exhale outside of that mean airway pressure, that's your Delta P. So it's the small amount of volume delivered with each breath. This is what is going to control your CO2 on your blood gas, or this is what's going to control your ventilation. Initial settings, it kind of depends on the baby, but anywhere from 20 to 30, depending on what is going on and whatever gives us good chest jiggle. And we'll talk about that too. Your hertz, this is how fast the oscillator is going to give these breaths. So for example, a hertz of 10 is 600 breaths a minute. You're going to take whatever your hertz is, times it by 60, and that's how many breaths the baby's getting per minute. We're always going to have a standard setting of between 10 and 12. I have seen it turned down to 8, and I have also seen it turned up to 14. It's not usually a setting that is adjusted very frequently, but I will talk about that here in just a second. So I do have a video here that is of, it's actually of a pig lung on the oscillator, and it just kind of gives you a good explanation or a good visual of what is going on inside the lungs when a baby is put on the oscillator. Just 1 second here. So right now, this pig lung is being ventilated just with a regular ventilator, just the way you and I breathe. And then here they're going to go ahead and switch these lungs over to the oscillator. So that's what they're doing right now. So do you see how the lungs are slowly starting to inflate? And that's our map. How much the lungs are going to inflate is our map. And then this little jiggle is our Delta P. That little bitty breath, inhale, exhale, is the Delta P. I don't want you to look at the settings too closely because we would never have our settings like this, so that isn't the greatest, but just you can kind of see how those lungs are jiggling. That's what's going on when a baby is on the oscillator. So example settings, kind of like I said, let's say doc wants a MAP of 14, a Delta P of 28, and a hertz of 10. If the baby is on conventional ventilation, they're on the Avia or on the Draeger, the physician or nurse practitioner is going to ask us as the RT, what is your MAP running right now? Because we can measure that on conventional ventilation. So I like to start about 2 above that. Your Delta P is not always, but the general rule of thumb is that it will be 2 times your MAP. Not to say you wouldn't have a MAP of 10 and a Delta P of maybe 19, you know, you could have fluctuations here or there, or you could have a MAP of 10 and a Delta P of 30, it might be more than 2 times, but you would never have a MAP of 15 and a Delta P of 16 or 17, if that makes sense. We're always going to start low to be as gentle as possible. And just to reiterate, the MAP is your distending pressure, controls oxygenation, and your Delta P is essentially your tidal volume or those tiny little breaths that are going to control your CO2 or your ventilation. Here is an example, kind of a management as far as how are we going to manage these kids. So if you are not oxygenating, kind of this first one up here, if you're not oxygenating, we're going to increase our MAP, obviously increase your FiO2, that's kind of a given. If we're not ventilating, or if we don't have a very good jiggle, say we get a blood gas 71182, obviously we need to do something, we're going to increase that Delta P. So we want to increase that tiny tidal volume, those tiny breaths that we're giving. We may decrease the hertz, and this is a little bit confusing. So what I want you to know is if you have a bad blood gas, like this one right here, the first thing you're going to do is go up on your delta P. If you've had 3 or 4 blood gases in a row and you have gone up on that delta P your whole shift, after that 3rd or 4th one, somebody, the RT, nurse practitioner, physician, is going to say, maybe we need to decrease that hertz or decrease our rate. The reason we're going to do that is decreasing the rate gives the baby more time to exhale and more time to blow off CO2, if that makes sense. It's the complete opposite of conventional ventilation. If you have bad gases on the Avia or the Draeger, we're going to increase our respiratory rate to blow off more CO2. But it is the opposite on the oscillator. It gives a longer exhalation time by decreasing the hertz so that the baby can blow off more CO2. So just know that it is the opposite, the rate. Changing the rate is the opposite on the oscillator. But like I said, you're not going to decrease your hertz with your first bad blood gas. It's going to be the 2nd or 3rd blood gas that you're going to like, okay, we've gone up on the delta P quite a bit. Now we need to decrease the hertz. At the bottom here, I have always monitor your chest x-ray for overinflation. You may need to decrease your MAP. One of the things they're really going to pay attention, very, very close attention to with these kiddos on the oscillator and on the jet when we get to that, is how expanded they look on x-ray in correlation to what they're setting. So we know that the MAP is going to affect oxygenation. But if we get an x-ray and the baby is very overinflated, say they are, 11 ribs expanded, it looks like they are overinflated. We can blow that balloon, say the lungs, I'm comparing the lungs to a balloon. We can blow that balloon up a little bit too much. When we have done that, we have kind of overshot the target of the goal of the oscillator. So we can cause PIE. We can cause those little tears in the alveoli. We can cause damage. So it can also be kind of confusing. Maybe your baby's not having a very good day. We've gone up and up on our settings. Maybe your baby's on 100%, and you get an order to you've gotten a chest x-ray, and you get an order to decrease your MAP. And you're like, now wait a minute. MAP controls oxygenation. Why are we going down on that when my baby's not oxygenating very well? It might be because on x-ray it looks like we are overinflated, and sometimes you'll find going down on that MAP will help the baby because we're not kind of causing that damage by being overinflated, if that makes sense. So the oscillator, it's considered to be gentle. We want it to recruit those alveoli, but it can be harmful if we're not paying very, very close attention to the x-ray and different things, if that makes sense. One of the most reliable ways to know that your oscillator kit is ventilating. Anybody knows what it is? It is the jiggle. So your jiggle is crucial to your patient's ventilation. If you're not visibly seeing the shake go on the chest and the abdomen jiggling, that means it's not happening in the lungs. If it's not happening in the lungs, that means the patient is not being ventilated and oxygenated. So you kind of want to look and pay attention to what your jiggle is when you start the oscillator. You'll see kind of the RT and the doctor maybe stand there when they very first put the baby on and just kind of stare at the chest, because if there's no jiggle going on, they probably need to up those settings just a little bit. So you have a jiggle and now you've lost it. Now, what do? You're 3 hours into your shift and everything's going great, and now all of a sudden your baby's desatting and you don't have a jiggle. You could suction. The tube might be slightly plugged with some secretions. Might need to reposition the baby. Maybe your ET tube placement is a little bit off. Maybe we're a little bit high. Maybe we're a little bit deep. if you have a one-sided jiggle, your ET tube could be displaced, again, high or low. You could have a pneumo. Lung compliance. This one is kind of a hard one to assess, but what I will tell you is if you come on and your baby is on 25%, they're doing great, their jiggle is so good, they're bouncing off the bed, and an hour into your shift, they have a fever. And then an hour later, you're up from, 25% FiO2, now you're on 50%. And your baby, something's going on, your baby is getting sicker, maybe they're getting septic, like I said, they have a fever, maybe they have a pneumonia going on. If your baby's lung compliance is changing because of something going on with their body, their jiggle is going to be worse. So you just kind of have to, assess your patient's condition and know that if your baby gets remarkably worse during your shift, or the opposite is true too. If your baby really starts to look and seem like they're getting better, if they didn't have a great jiggle at the beginning of the shift, their jiggle might be great towards the end if you're able to wean your O2 and they really are looking better. So lung compliance has some, the elasticity and the bounce of your lungs can affect your jiggle also. You've tried all these things, nothing's making your jiggle come back, your baby's desatting, maybe now their heart rate is dropping. Sometimes the baby just needs to be reintubated, and that goes for any, form of ventilation, not just the oscillator. So, cannot stress enough how important it is to know and watch your jiggle. It really should be talked about in report. Maybe your kid has never had a great jiggle. That's something you want to know when you come on. Ask your RT if you've never taken care of the baby. Have you taken care of this baby? Is her jiggle usually look like this? It's just very important to know what that's looking like, especially if you get a blood gas and it's not great. Your nurse practitioner is going to want to know, well, did they have a good jiggle before you got the gas? As far as troubleshooting and management, when you're taking care of these kids, suction PRN and before blood gases, you're going to call RT for all repositioning. The policy says 2 people, but the ET tube and the ventilator is our only focus. So we're going to be in that room a lot. So don't hesitate to call us. And let's talk about alarms. The oscillator can be a little finicky because kind of anything between the machine and the baby's lungs, anything that can kind of happen in between that can cause the oscillator to alarm. So if the baby needs suction, that is going to, cause a little bit of pressure because that's, secretions in the lungs. Our Ballard suction catheters, the actual suction catheter of the Ballard is enclosed in like a little Ziploc baggie feeling kind of sheath. If that's pulled back too far and you can create like a little tear in that Ziploc baggie kind of thing, that can create a leak and that can cause the oscillator to alarm. The suction port where you put the saline, if that's left open, causes a little bitty leak and make the oscillator chirp. Again, patient lung compliance, like we talked about. If your patient's getting sicker or getting better, sometimes the oscillator just needs tweaked just a little bit. The settings are still the same, but the oscillator runs on like a measurement, and so it's measuring that maybe your lung compliance is different, so it might alarm a little bit. If your patient's breathing over the oscillator, not necessarily a bad thing until it is. And what I mean by that is, say you have a baby who doing great. Our goal is to switch to conventional ventilation, switch over to the Avia sometime on your shift. We're on 25%, not having very many DSATs. It's okay if that baby breathes over the oscillator because we want that baby to breathe normally when we put him to the Avia or the Draeger. So that baby, it's not really an issue if they breathe over. It might cause the oscillator to beep a little bit, but again, not a huge deal. However, if you have a big, sick meconium aspiration kid, severe sepsis, and they are hemodynamically unstable, they're on 80% oxygen, their gases aren't great, and they are breathing hard and fast over the oscillator and they're desatting every time they move, that patient, that's a conversation that needs to be had. That patient needs sedation, or that patient needs more oscillator settings, because we are not giving that baby what he needs. As sick as he is, he should not be using energy to breathe over the oscillator, if that makes sense. Water in the circuit happens if the humidifier runs dry, we've accidentally let our bag of water run out, any kind of leak in the system, if the oscillator becomes disconnected anywhere or the baby is extubated, all these things will cause your oscillator to alarm. And what are you going to do? You're going to keep calm and call us, or you can freak out and call us. Either way, biggest thing to remember is if your oscillator is alarming continuously and you hear it shut off, which means it's beeping and the sound of the breath has completely stopped and you don't hear that, that means the oscillator has stopped and now your baby is not getting any ventilatory support. You need to grab your ambu bag, and as you're doing that and bagging the baby, you call us on Vocera, and I need you to say, I need you to come to room 3 right now. My oscillator's not working, I'm bagging the baby. Don't say, can you just come to room 3 whenever you get, I mean, like, no, you got to tell us, you know, something's not right, and we will come running. But you will not get in trouble if you bag the baby, especially, like I said, if the oscillator has shut off, that baby's not getting their breath. As far as weaning, when are we going to wean the baby to conventional? Obviously, we always want to get that FiO2 down first. And I have, except when lungs are overinflated on x-ray, I mean, obviously we'll wean that MAP before we'll wean the oxygen if we're overinflated, kind of like I talked about. And then we're going to wean that MAP in increments of 1 to 2 until we get to a setting of 8 to 10. Wean the delta P in increments of 1 to 2 until we get to 20 to 25, and then we will switch to conventional. Lots of things are going to go into when we will switch the baby, their patient's condition, physician preference, blood gases. It's a lot of different things, but this is kind of a general rule of when we would switch. Okay, now we are going to move on and talk about the jet. The jet is going to have a lot of similarities to the oscillator. The jet and the oscillator are both a high frequency ventilator. So the same kind of lung mechanics, same measurements, but there are just some slightly different ways that they operate. The jet is also an unconventional lung protective form of mechanical ventilation. That's exactly what the other slide said for the oscillator. Also gives small, unmeasurable tidal volumes, delivered at very high frequencies, rates of anywhere from 240 to 660. This one is not called a hertz. Remember, the rate on the breaths per minute on the oscillator was called a hertz. This is called a rate. Active inhalation, passive exhalation. The jet is going to push that breath into the baby's lungs, but it is going to passively exhale. The jet does not pull the air out of the baby's lungs, and we'll talk about why that's important. Maintains lung recruitment, hopefully preventing lung injury from overdistension. The jet uses less mean and peak pressures to ventilate and oxygenate. So less MAP than what is required on the oscillator, and less pressure is always the goal. Less pressure is what is going to prevent lung injury. Here is what the jet looks like. We've got the machine here on the left-hand side, and then it uses this, it's called a whisper jet box. This box does have to be in the bed with the baby, as you can see. It does make a little noise, but it is very quiet. If you haven't seen one, and you're working, see if you can go into a room where it's running, because you do know it's there, this little box, but it is pretty quiet. Okay. The different values and what do they mean and how does the jet work and all the things. This middle section here, the green section, are the controls. This is where we're going to set our settings, and these first three numbers here, these will actually be orders. This is what your orders will say, is this section right here. So we're going to have a PIP. Remember, that's your peak inspiratory pressure. That's the size of the breath that the jet's going to give. The PIP is going to be what controls your CO2. Your rate, we won't change it a ton, but we may change it to adjust and manage our CO2. Obviously, that's how fast the baby is breathing. We might decrease it for extremely low CO2, or we might increase it for extremely high CO2. I time always stays at 0.02. So it is an order, but it won't change. And then our I to E ratio, inspiratory to expiratory ratio, this is just something that's calculated based on the rate. Up here is our monitored stuff. So all of these numbers can fluctuate, but this is kind of what's going on in the baby's lungs. So this PIP up here is our measured PIP. So remember, that's the size of the breath. We want it to match-ish with this number down here. As you can see here, it's 15.5, and we're set at 14. It's going to fluctuate a little bit. Our PEEP, this is also a measurement. So our PEEP will actually be dialed in via a conventional ventilator, and I'm going to show you a picture of what that looks like. No idea why, but the jet people, when they invented this machine, you literally cannot set, there's no PEEP on this machine. You have to use another machine to deliver the PEEP. So there is a Draeger or an Avia somewhere over here with a PEEP set of 5, and then this is the measured. So we want that to also kind of match. This servo, this is that number I kind of talked about at the beginning. It's just like a trending value. This tells us how much flow it's taking for the jet to give the baby their breath. And it's just kind of a, like I said, a trending number that we as RTs follow and kind of pay attention to. It just kind of tells us that everything from the machine all the way to the baby's lungs is working properly and that there's no hiccups. There is a high and a low limit. So if this gets outside of the range that we have set, it will alarm. And we'll talk about alarms in just a minute, but it's really just a trending value. Your delta P. So here's that delta P that, we kind of talked about with the oscillator. The delta P, all this is the difference in your PIP and your PEEP. Remember I said that the delta P is a change in pressure. This is just the measured numeric difference between your PIP and your PEEP. Changing your delta P, so changing these two things, is going to affect your ventilation or your CO2. The same way that changing your delta P on the oscillator affects your CO2. The measurement here for the MAP, again, the mean airway pressure, that average pressure in the lungs that's kind of always there. This is the average pressure of your PIP and your PEEP together. So these two numbers also affect the MAP or your mean airway pressure. Again, on the oscillator, these things are a setting. On the jet, these are a measurement, if that makes sense. They're kind of a byproduct of when you set the PIP and the PEEP and that kind of thing. So as you can see, it functions the same-ish with the same, kind of the same settings and the same principles, but on the oscillator, we are dialing in certain settings, and here we're dialing in different settings, but we still get those same measurements. if that makes sense. I'm going to talk real briefly about this ready light up here, this green light. When we very first hook the jet up, it does take a few minutes, and it can take like 3 to 5 minutes for the jet to kind of stabilize all these numbers. During this time, this green light will not be illuminated. That means that the values are all calibrating to the pressure and the compliance in the baby's lungs. The jet is ventilating the patient during this time, but the ready light being illuminated indicates that all numbers have stabilized and that all the alarms are set during this time. So that's just what the ready light means. Here we have the alarm silence button. Standby, us as RTs will use this if the physician wants to listen to heart sounds and they want the machine stopped temporarily, we will push that. And then if for some reason the machine ever does get stopped or paused, the enter button restarts it. All this down here is humidity, water humidification. Okay, why did we buy a jet? Why are we using a jet? The oscillator's been good for how many years now? Why do we want to use the jet? So the first thing is remember that active and passive exhalation. The oscillator pushes that breath in and pulls it out. What does that mean? The jet uses passive exhalation, and why, and I'm going to tell you that that is a little bit better, but why is that better? Anytime you force exhale or suck air out of the lungs, there is the potential for air trapping. When you pull air out of the ET tube, where the ventilator circuit is hooked to, when you pull air out of the trachea, the pressure in the upper airways dramatically and quickly lowers, while the pressure in the distal airways, which is the alveoli, that pressure does not lower as quickly or sometimes at all. So you're pulling that breath out of the ET tube, out of the upper airways, but it doesn't all get pulled out. Because of that, you have some air that just hangs out in the lower airways and can cause air trapping. Air trapping is one of the things that leads to PIE. So that's one of the main reasons why some physicians really prefer the jet, if that explanation makes sense. The jet also uses lower pressures overall due to that passive exhalation. Because if you don't have this air hanging out, this air trapping, this dead space air that's hanging out in the distal airways, if you don't have that, you don't necessarily need as much pressure to ventilate the lungs. Also, the oscillator can be used to prevent PIE, but it cannot fix or heal PIE. The jet can actually, if it's used correctly, it can fix and heal a baby's pulmonary interstitial emphysema. It can heal their lung damage. And how that works, the jet uses a very high velocity, small tidal volume jet breaths. Those tiny jet breaths actually do not penetrate the injured area of the lungs. So when you have PIE, that is an area of the lung that has very, very high resistance or very low, poor lung compliance. And the jet breaths actually cannot get to that area of the lung. That allows that area of the lung to rest and heal if it's not being ventilated. Contrary to this, the oscillator just keeps ventilating all areas, which can potentially cause more damage to that affected area that has the PIE. It's almost like the jet ventilator is like a very considerate ventilator. It sees those high resistance PIE areas, and it's like, oh, okay, I'm not going to give my breath to that area. I'm going to let that area heal. We're just going to ventilate the rest of the lung that is not injured, whereas the oscillator doesn't see the difference. It just gives its breath everywhere, if that makes sense. So moving forward in our NICU, the goal will always be to use the jet first for extremely low birth weight, micropreemies, less than 28 weeks-ish. However, at this time, we do only have 2 jets. So if those are both being used, we will have to use the oscillator on if we get, more than we're using those and we get another micropreemie, we will have to, still have to use the oscillator. But moving forward, our oscillator will be used more for the difficult to manage blood gas babies, severe sepsis, high drops, diaphragmatic hernia, those kids who need ventilated with those high pressures, if that makes sense. I do have a short video that does a good job of kind of explaining the jet.
Introducing the LifePulse 204, advanced high-frequency jet ventilation technology for infants. LifePulse 204 represents a new generation of high-frequency jet ventilator. Conventional ventilation delivers relatively large tidal volumes and long inspiratory times. The delivered volume reaches the distal airways and developing alveoli. Conventional breaths can stretch the delicate small airways and fragile alveoli. These breaths also risk restricting pulmonary blood flow and creating or aggravating pulmonary air leaks. The LifePulse offers important clinical advantages compared to conventional ventilation and other forms of high-frequency ventilation. Unusually small tidal volumes, combined with exceptionally short inspiratory times, create the lowest possible peak and mean alveolar pressures. The gentle breaths from the LifePulse allow air leaks to heal. An adjustable inspiratory time that doesn't change when rate is changed enables IDE ratios of up to 1 to 12. Perfect for avoiding gas trapping. Passive exhalation is possible by exhale gas following the path of least resistance, swirling out and around the incoming gas. Less mean airway pressure is required to maintain airway inflation during exhalation. Experience this unique, life-saving therapy for yourself.
Just a nice visual of kind of how the jet works. And there are quite a few more videos that I can show you that the Bunnell, which is the manufacturer of the jet, puts out that are very, very user-friendly and explain things in detail if a video kind of is helpful. But here is that link if you guys want to watch that again. Okay. Just kind of a quick slide. This is kind of similar to the one I showed you at the beginning on the oscillator slide, but again, this is that regular breath, conventional ventilator, just how you and I breathe. We've got this high pressure at inspiration. Here is the oscillator breath, and here's our, our mean airway pressure here. Here is the jet breath, and as you can see, using much less pressure. So this is just kind of the goal. Less pressure. We want to give enough pressure to keep the baby ventilated and oxygenated, but we don't necessarily need so much pressure that we're going to cause lung injury. Okay, so here is what the jet will look like in a patient's room. Like I said, we have to use a regular ventilator to be able to deliver that PEEP. So it does get a little bit crowded in the room, but here's what it does look like. So we're going to use the jet in conjunction with the conventional ventilator. Remember to adjust both FiO2 knobs. So this ventilator is giving oxygen, and this ventilator is giving oxygen, and so you have to adjust. If you're going to increase your oxygen or decrease it, you have to do both. So you're going to increase your oxygen on your Draeger or your Avia, and then you're going to increase your oxygen here on this little gray box here at the bottom of your blender. It won't hurt the patient if you forget and turn one up or turn one down and not the other, but the patient will get kind of a mix of in between. So if you turn your Draeger to 30% and this still says 25, your patient's probably going to get 26, 27%. They're going to get a mix of the FiO2 if you don't. So it does not hurt the patient, but it just won't be, your charting probably won't be exactly accurate of what they're getting. Jet may shut off with suctioning. Okay, so if it's your first time having a jet patient, first of all, just tell your RT that, and we will be in the room. We'll be in the room a lot anyway, but no, there's nothing to be embarrassed about with your first one, that you're, confused and nervous and all the things. With suctioning, sometimes you are decreasing that pressure because you are applying suction to the circuit. So we're not sure why it happens sometimes and why it doesn't. I think it is when the patient is on pretty high settings on the jet that this happens, but sometimes it will shut off. So call your RT with the first time that you have to suction, and then we can walk you through that and what to do. But it is a large pressure drop when you suction. But we will suction PRN, and as usual, before blood gases, that kind of thing. So remember those yellow monitored values at the top. Those will fluctuate with any kind of changes in the lungs or changes in the pressure or changes in the circuit, just like we talked about with the oscillator. Water in the tubing, patient's coughing, patient needs suction, leak in the system, all those things, these numbers will fluctuate and possibly alarm. Call your RT, call your RT, call your RT. If you are confused, if it's alarming and won't stop, just give us a call and we will come fix it. The nice thing is these alarms will fix themselves 90% of the time, but sometimes it can take a couple minutes for that to happen. And also, you will have a jiggle with the jet, but it will be a less pronounced jiggle than on the oscillator. So it's still there, but it's quite a bit less because we're using less pressure. Okay, we're going to talk briefly about alarms and a sigh breath. There's only 2 alarms on the jet, the MAP and the servo. They are both auto set, but we can widen them a little bit. Most of the alarms are low priority alarms, and those thankfully account for about 90% of the jet alarms, and those are also the ones that are going to fix themselves. There are different sounds and lights for the different alarms. There's low priority, medium priority, and high priority alarms. As you're taking care of a baby on the jet, you'll figure out which are which. But again, do not hesitate to call us. If it's your first time and your jet's alarming, just call us. But just like the oscillator, here's the list of things that can kind of make the jet alarm. As you can see, it's all the same things as the oscillator. Okay, so a sigh breath. With the jet, we have the capability so we're giving the baby these itty bitty tiny little breaths, 500, 400 a minute. We do have the opportunity to give the baby a sigh breath on top of those breaths. And what does that mean? I mean, it's literally like if you and I are sitting here and we have to yawn or we have to take a big, deep breath. We have the capability to dial those in via the conventional ventilator, so the Draeger or the Avia. Why would we do that? So sometimes on the jet, the babies can get areas of atelectasis, so a little area of consolidation that you just can't pop open. And atelectasis is not good either. It's not as bad as PIE, but it's not good. So if you give a sigh breath and give a baby kind of a big, deep breath, maybe you give that baby 5 big, deep breaths a minute, it kind of can help open up those areas of atelectasis or consolidation. So that is what a sigh breath is used for. We're going to give a rate of just 4 to 10 per minute, and we will have to set a PIP because we do have to set how big we want that breath to be. But basically, just to treat atelectasis, it's not super ideal because sigh breaths do increase the overall pressure in the lungs, increases the pressure in those distal airways, which can cause lung damage, as we know. So some doctors are fans of it and some aren't. Sometimes you have to use it for like a shift, like 12 hours, and then they'll turn them off. You might also use a thigh breath for a baby who's apneic. And I know that sounds kind of confusing because you're like, what do you mean the baby's apneic? They're on the ventilator. Babies will breathe over the jet, just like they'll breathe over the oscillator. Same rule applies. Sometimes it's okay, sometimes it's not. But every once in a while, you'll have a baby on the jet that's not breathing over at all, and that's okay. But when they're not breathing over, they are dropping their heart rate and their SATs. So that baby is apneic in the sense that they're not taking their own spontaneous breaths. Most of the time that in that case, we just need to increase the jet settings, but some physicians will give a sigh breath to just kind of keep their, so that their heart rate and their SATs are not dropping, give them those sigh breaths, 4, 5, 6 times a minute. It will primarily be used though to clear the areas of atelectasis. The Avia and the Draeger does have that manual breath button that you can give the baby a breath. Our physicians do not, under any circumstances, want us giving manual breaths on the conventional ventilator to our babies. If your baby is decompensating and you have to take them off in bag, that's something different, but we are not to use the manual breath button. Weaning from the jet. Again, first goal is always to wean that FiO2, and then we will wean that PIP in increments of 1 until we get to a PIP of 10 to 12. And then these kids, we might switch to conventional, or they might just extubate directly from the jet if they're doing well. I've seen it done both ways. Okay, now we're going to switch to conventional ventilation. This is just regular ventilation, how you and I breathe. There's a few different ways we can deliver it, obviously, but we are done with the high frequency part of the talk. Here are what we're going to talk about, the Avia and the Draeger, 2 conventional ventilators that we use here in the NICU. One is like the iPhone 8 and one is like the iPhone 12. They both do the same thing, but one is an upgraded version. Here are all the modes of ventilation we can provide with these 2 ventilators. Okay, so what is what? This mode is called pressure control SIMV. What does that mean? Pressure control, synchronized, intermittent, mandatory ventilation. This mode, we are going to set a peak inspiratory pressure, or a PIP, an end expiratory pressure, or a pressure at the base of the lungs on expiration, a rate, a pressure support, and an I time. This has classically, I've been doing this 20 years, this has been the mode we have used the majority of the time over the last 20 years for all of our intubated neonates. We are switching more to volume mode, which I will talk about that here in just a minute, but this is kind of an old tried and true. So the volume of each breath is variable. So we're going to set that PIP. So say we have a PIP of 20. So here's your PIP of 20 going in. The volume in mils is going to be variable with each breath. You can have a set volume or you can have a set pressure. You cannot have both. So the volume of breath is variable. The ventilator is going to give both mandatory breaths and patient demanded or spontaneous breaths. Your ventilator breaths will be bigger than your spontaneous breaths. Here's a vent breath. Here's a patient breath. Here's a vent breath. These are spontaneous breaths. This mode can be used all the way for moderately sick neonate or babies with poor ABGs, all the way down to babies who are ready to be extubated. Like I said, this is kind of a jack of all trades mode. Also, when we talk about tidal volume, the volume of each breath is variable, but our goal is always for each breath to be 4 to 6 mils per kilogram. So if your baby weighs a kilo, their measured tidal volume should be around, 4 to 6. And we'll talk about that more when we get to volume mode. ECAC. What does this one mean? very similar to SIMV, but remember when I said in SIMV that the patient's spontaneous breaths will be smaller in size than the ventilator breaths? All these breaths in PCAC are the same size. So we're going to set a PIP, a PEEP, a rate, and an I time, no pressure support. That assisted pressure that assists the patient's spontaneous breath is no longer there, because even if the baby triggers a spontaneous breath, which is what's happening right here, the vent knows to give the same size of breath. So the breath will be the same PIP, or if we're in a volume mode, it'll be the same tidal volume. The baby can breathe spontaneously as much as they want, but every single breath in this mode will be the same size. This is ideal for patients with chronic lung disease, poor blood gases. The statistics show that assist control decreases work of breathing because the baby's getting the same size breath with each time they take a breath. You're not getting a big breath and then a few little breaths, which for babies with chronic lung disease or poor blood gases, that can make them feel like they're working a little bit harder when they have to take those smaller breaths, if that makes sense. What is volume guarantee? Volume guarantee is just, we are going to set a volume instead of a PIP. So these previous two modes I was on, you can be in PCSIMV, but instead of a PIP, you have a tidal volume. It's the same thing, but now we want a set tidal volume, not a set PIP. The volume guarantee is not its own mode. It's just a different way of providing these two modes, but instead of setting a peak inspiratory pressure and your volume is variable, we're going to set a tidal volume with these two modes and your pressure will be variable. Why do we want to use volume guarantee? The recent studies show that the changes in the size of your breath in mils, if you have large variations in the change in the size of your breath, that can cause lung injury over time. So for example, in this mode, this volume maybe is 10 mils, and then a 5 and a 4, and then a 9, and then a 3 and a 4. A big breath and then little breath, big breath, little breath can cause lung damage, is what the latest statistics show. So the physicians want us to be using a volume mode so that each breath is the same size-ish in mils, if that makes sense. So in PCAC, all of your tidal volume breaths, all the volume in mils will be the same. In SIMV, these will still be a little bit smaller, but it's still going to kind of target it to be at the same tidal volume-ish. So our target is 4 to 6 per kilo. I don't have a photo of this because it's essentially the same as these two. You're just setting a tidal volume instead of a pressure. For the last 20 years, we have ventilated babies in pressure mode. We never, ever use volume. This is kind of a new thing within the last few years, and it's just because of the latest literature and physician preference is what I will tell you. Management when you're on just a regular conventional ventilator. How are you going to increase or decrease these settings? If you're not oxygenating, your gas is okay, but your baby's not oxygenating well, we might increase that PEEP. So if you're on a PEEP of 5, you might go to 6 or 7. PEEP is what's going to help control oxygenation. Obviously increase your FiO2. And then you might increase your PIP or your tidal volume. You might give the baby a bigger breath. And that obviously sometimes helps with oxygenation. If you're not ventilating, your blood gases are not good. Your CO2 is very high. You're going to increase that respiratory rate to blow off CO2. Increase your PIP. You're going to give a bigger breath. If you give a bigger breath, that blows off more CO2. If they're in that SIMV mode, you might increase your pressure support. That's that supportive pressure on the baby's spontaneous breath. So you might help make the baby's spontaneous breath a little bigger. And then if you're on the lower end of that 4 to 6 mils per kilo, you might increase your tidal volume. What does the ventilator look like? Here's like the screens of both of the ventilator. So this baby's in pressure SIMV. If we were in volume mode, it would say volume guarantee up here, but here's kind of all your settings down here. This baby's on a rate of 40. On the this baby has a set PIP. So here's our inspiratory pressure. The AVIA decided to make it real confusing, and the AVIA people, we have to add this number and this number together to get our PIP. So this baby is actually on a PIP of 20. When you think about it, it does make sense. This is the pressure at the base of the lungs on exhalation. This is the pressure in the lungs always, your PEEP. This is your peak inspiratory pressure. So when you add those together, your total pressure is 20. So, but it is kind of confusing. So this baby's on a PIP of 20, inspiratory time 0.35, pressure support ventilation is 10. So think of pressure support ventilation as the baby's spontaneous PIP, the size of the breath when the baby takes their own breath. So if our vent breath is at a PIP of a total pressure of 20, the spontaneous breath is at a total pressure of 15, just a little bit less than the ventilator breath. This is how easy it is for the baby to take a breath, the trigger, and here is your FiO2. On the Draeger, same-ish idea, a little bit different though, a little bit upgraded. Pay close attention. On the Draeger, your FiO2 is in the spot where your rate is on the AVIA. We are really trying to not have twins on two different machines because we have already had variances on this where a nurse or an RT went to go turn up the FiO2 and accidentally turned up the baby's rate, thinking they were turning up the FiO2 because the patient, it was twins in the same room, two different ventilators. So we are really trying to not do that, but just make sure you know which one you're turning up your FiO2 on which vent. So this baby is in a volume mode. They're on that PCAC. All this baby's breaths, all their breaths are going to be the same size. They're on a tidal volume of 6. So maybe this baby weighs like 1,200 grams or so. I time is 0.4. Baby's rate is set at 40. PEEP of 8. And we don't use a slope on infants, but we can't turn that off. All of this is all of your measured stuff. This is all things that we keep track of. I will tell you if on the Draeger, how I talked about where these two numbers are added together, if this baby was in a pressure mode, we do not add the numbers together on the Draeger. So again, with your orders, if we were not in a volume mode over here, if this was a pressure and this was 20, a PIP of 20, this would actually say 20, not 15, if that makes sense. Troubleshooting, alarms, auto cycling, all the things. If your vent says it's auto cycling, it says that your baby is breathing more than 100 times a minute. Well, it could be that your baby is tachypnic. We've all taken care of those kids, RDS kids that are breathing like a freight train, super tachypnic. But if you don't think that's the case, if your baby's not been tachypnic all shift, and then all of a sudden it says your vent's breathing 140 times a minute, it could be something with the ventilator. How a ventilator works is it has to sense an endpoint. So that breath goes in, it senses the bottom of the lungs, the pressure in the lungs, and that's what tells the ventilator that it can stop giving the breath. If there's anything in the circuit or a leak in the circuit that the vent doesn't get to that endpoint, it's going to keep trying to give that breath until it senses the endpoint, if that makes sense. So what are things that can make it auto cycle because it's going to keep giving a breath? If that port on the suction catheter is open, your suction catheter is pulled back too far, like I mentioned earlier, causing a little bit of a leak, the vent is just going to try to keep giving breath and it'll be auto cycling. It's not really, the patient's not really breathing that fast. If there's water in the circuit and it's sloshing back and forth, that will seem like the vent is giving breath when it's really just water in the circuit. The flow sensor is the little thing at the end of the ET tube that gives us all of our information. If that gets wet or soiled, it can make the vent do all kinds of crazy things. If your patient is extubated, if your patient's self-extubated, there is no endpoint because that tube has come out, and so it's going to keep giving breath. So the auto-cycling alarm is kind of one of the first alarms, like before things before the vent starts alarming other things, it will alarm like auto-cycling or high rate first, and then kind of start alarming some other things if there's other things wrong. If you have a large ET tube leak, sometimes we'll get, because again, ET tube leak is just a leak in the system when you think about it, and so the vent might be trying to give more breath. Low minute ventilation, again, is just a leak in the circuit somewhere. Patient has become disconnected, extubated, ET tube leak, same kind of thing. So those are leaks in the system or something in the circuit causing it to think it's, needs to give more breath. On the opposite, we have pressure limit, volume limit, circuit occlusion. This is, we are hitting that endpoint too quickly, or that endpoint, the pressure in the lungs is all of a sudden really increased or really high. So this is like a high pressure or an occlusion kind of alarm. What causes this? The patient's hiccuping, coughing. How our babies kind of bear down and they kind of hold their breath when they stretch. Patient needs suction. We've got a ton of secretions in there that's causing increased pressure, or a lung compliance issue. We're getting sicker, pressure is increasing, or could be water in the circuit. So anything that's going to kind of cause us a high pressure is going to cause one of these kinds of alarms. Okay, so kind of buttons that you guys need to know about. Alarm silence on the Draeger. Down here, this little yellow button, alarm silence on the Avia. O2 suction or increase O2. So over here, it's called O2 suction. Over here, there's the increase O2 button, and then there's a suction button. First of all, over here, these two things do the same exact thing. If you accidentally hit suction, no big deal. Back in the olden days, before we had Ballards, we had to disconnect the circuit and put a sterile suction catheter down a baby's ET tube. And if you push this button, it did provide them the increase O2, but it also stopped the flow of breath through the ventilator because we were disconnecting the circuit. So it didn't continually spray vent water in our faces, which was so nice back in the day. But if you accidentally hit suction, it's okay. Over here, it's called O2 suction. Basically, this is your oxygen boost. If your baby's desatting and you want to give them a little boost of oxygen, you're going to push these buttons. What does it do? Over here, you hit this, it gives the baby 3% more than what is set for 2 minutes. So you're going to push this button, it's going to give this baby 43% for 2 minutes, and then it's going to go back to 40% on its own. Over here, you hit O2 suction, a little bit different. The Draeger gives 10% of whatever your FiO2 is set at to the baby for 2 minutes. So this is 3% above this is 10% of what is set. So if you're on 80%, your baby's going to get 88% of a boost for 2 minutes, if that makes sense, because it's giving you 10% of whatever your FiO2 is set. Manual ventilation or manual breath. Here it's manual breath. Here it's called manual inspiratory hold. You can give a baby an extra breath if you feel like they are really desatting or if their heart rate is dropping. This gives baby an extra breath without taking them off and bagging is what these do. What I will tell you is if you're having to use this button, this is a conversation with your RT, your nurse practitioner, your physician. That baby, if you're having to use manual breath button all the time, that baby's not getting enough ventilation through the vent. And so we need to be increasing that baby's respiratory rate or increasing the baby's tidal volume or their PIP, because if you're having to use manual breath all the time, we're just simply not giving them enough. Also, if you are weaning your kid hard and fast and they want to get this kid extubated, and then you get to a rate of 20 and you're having to use this manual breath button, that kid's not ready to be extubated, because if they're not breathing over the ventilator, on the ventilator, they're not going to breathe when you pull the tube out. So I would not say to be using it all the time, because that's just, something's not right if you're having to use it all the time. This alarm reset button here will just reset whatever alarm went off. If you accidentally hit it, it's not a big deal. Again, if your vent is alarming and it's not stopping and you don't know what's going on, call us. When all else fails, if you think they're disconnected, you hear a big leak, and you'll hear it. It'll be like a whooshing sound, and you don't know what's wrong, and their heart rate's dropping, and their sats are dropping, and you just don't know why. Grab your ambu bag and just bag them and call us, kind of like I said earlier. We need you in here now. Weaning from the conventional ventilator, obviously going to be based on your patient's condition. If it's a super, super sick kid, even if their gases are better, but they're still on antibiotics and they're still seeming kind of septic, we're not going to extubate that kid. So kind of just based on their condition, based on their gestational age, gases, we want their PIPs to be down 14 to 18. We want their rate to be down, FiO2 to be down. In volume mode, we're not going to like crazy wean that volume, because we always want our breaths to be 4 to 6 mils per kilogram. But if we're like 6 to 7 mils per kilogram, we might wean that tidal volume just a little bit to get it down before we would extubate. Woo! Okay, we've extubated our baby. Now we are on nasal CPAP, nasal IMV support. What does that mean? I'm going to kind of talk about these few things, and we are almost done. I'm so sorry that this talk is so long, you guys. Okay, a couple different ways we can give nasal ventilatory support. The RAM cannula, we've had this for a long time, looks just like a regular cannula, nice and comfy, nice and soft. Comes in 4 sizes, works well for most babies. We change it every 2 weeks. And then over the last year or so, we have purchased and have been using this Flexi trunk. This comes with 2 different interfaces, the prongs and a full mask. Why would we use a Flexi trunk versus a RAM? Well, a couple different reasons. The RAM, the smallest size RAM, the prongs are so close together that it pinches the baby's nasal septum. And every once in a while, you will get that 24, 25 weeker or like an extreme IUGR 27 weeker who can be extubated. But we have found that the smallest RAM cannula, it just pinches their septum so much. And then the next size up is too big for them. We actually had a baby once that it pinched their septum to nothing. There literally was a hole. They had one big nostril, basically, because the septum was gone. It was awful. We had to have plastics come see that baby. So we wanted something else that we could use that obviously was going to be better for their nose. And then that's where this came into play, that we could use this little mask for, these itty bitty babies that the ram cannula was not gonna work. We can also then switch between these two, and then there are two different sets of pressure points that, you're not having excoriation from a mask 24/7, you can kind of switch back and forth. And then another thing that we can use this for, the ram is designed to have a leak. There is going to be some air the ram does not fit super, super tight in the nostril, and some air does leak out, and that's okay. Most babies tolerate that just fine. But maybe you have that kiddo that's been on the ventilator for a really, 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 really long time, and you want to try extubation, and you really want them to succeed, but they need more of a tighter fitting system because they need all their pressure. They need all that flow that the ventilator is giving them. They need all that FiO2, all the things. You might use the flexi trunk on that baby just to give them the best chance possible to be able to be extubated, because we've got that tighter seal, if that makes sense. So the ram works for most, but the flexi trunk is there for those itty bits or babies who just need their extubation facilitated a little bit better with like a better seal, if that makes sense. Okay, so two different ways we can give nasal ventilation. Nasal IMV stands for non-invasive mechanical ventilation. We are actually going to give pressure breaths through the baby's nose. It's going to help facilitate extubation in neonates who still require some ventilatory support. For moderate apnea, maybe their gases are kind of moderate, but we are going to set a PIP, so the size of the breath, a peak inspiratory pressure, a PEEP, there's an I time, and then how many times are we going to give that breath. I'm not sure if any of you have ever worked with a patient, an adult on BiPAP, maybe in school, or if you've worked in other facilities. Nasal IMV is like putting a patient on a BiPAP. It's going to give those breaths so many times a minute to help kind of overcome poor blood gases or apnea. This is what your screens will look like in non-invasive ventilation. So we have a rate of 25. This baby's on a PIP of 20. Remember, we're going to add those together. I time is always 1, and we're on 40%. Over here, it's a little different. They say different things, but this is both nasal IMV. This baby's on an FiO2 of 30. We're on 20 over 5. I time is 1, and a rate of 20. Not sure why, but on the Draeger, there is no O2 boost, that increase O2 button, O2 suction. It is disabled in non-invasive mode. We are not sure why the manufacturers did that, but you have to physically increase your oxygen on this mode, but you can still use your boost over here on the Avia. Okay, nasal CPAP. Nasal CPAP is just a continuous positive airway pressure, just a constant pressure in the lungs via the nares. It was introduced in 1971 by a gentleman named Dr. Gregory. Prior to 1971, the mortality rate for babies with RDS was 90% if your birth weight was between 750 and 1,500 grams. CPAP has saved a lot of lives. So constant pressure in the airways on both inhalation and exhalation enhances airway patency, lung recruitment. Initial setting of 5. I've actually seen them go up as high as 10. 8 really is the highest. And then they will go as low as 4 before DCing. They do want the babies wean FiO2 to room air or close to room air before DCing. Here's what your vents will look like in CPAP. This one does still say, because it's the same mode, we just have the rate turned off. This one does, it is a little bit different, but these babies, CPAP of 5, 40%. CPAP of 5, 30%. The Draeger does have the capability to give like a manual breath in CPAP mode. So that's why there is a PIP setting. This is not something that we really use here, but that's why you will see a PIP setting in this mode. It is not active. It's just if you would have to give a manual breath, which we don't really do in CPAP. So, but it is there. Troubleshooting nasal CPAP and nasal IMV, really the biggest thing is just keeping it secured to their face. We do get some water and rain out in the tubing. We have to pay attention to the patient's nose. Remember, like I talked about, we do, even the bigger kids can get some breakdown, so we use the Duoderm. And we have used AYR gel before if we do get breakdown. If baby is having a ton of alarms, DSAPs, Brady's, and they're laying with their mouth wide open, they might need a chin strap because some of that air might be leaking out of their mouth, and that could be causing some DSAT. As far as keeping it secured to their face, you're going to be able to tell the kids who can tolerate if their CPAP falls out of their nose or if that flexi trunk comes off. A 26-weeker that was just extubated that's, you know, on 30-40% oxygen, not doing the greatest, their condition's going to deteriorate very quickly if that comes out of their nose. Your term kiddo that, you know, our plan is to DC it in a couple hours, you might walk in and they've pulled it out and they're not even alarming. So it's always important, obviously, to keep it secured to their face, but some babies will tolerate it better than others if it comes out. Okay, I'm going to talk real briefly on what nitric is because it is a machine that we use in conjunction with ventilator support. It could be a whole class on its own, so I'm not going to go into great detail, but if you walk in and you see nitric, I want you to know what it is. Nitric is an inhaled gas that we put in line with the ventilators. Indications: PPHN, persistent fetal circulation, meconium aspiration, pneumonia, sepsis, all these things. Basically, any disease process that's going to result in severe hypoxia. If they have PPHN, that's going to be obviously diagnosed by an echo. Nitric oxide is a very, very potent vasodilator. So if you have high pulmonary pressures caused by PPHN or caused by severe sepsis, nitric oxide is going to bring those pulmonary pressures down. Most effective in term, near-term infants. We do use it for micropreemies. It doesn't always work. Micropreemies problems stem from, remember those first few slides, not having enough alveoli, and then the alveoli that they do have, some of them have the little tears in them. Their problem isn't a high pressure in their airways. That's not their problem, or the pulmonary hypertension is not their problem. But we do use it on micropreemies as kind of like a last ditch effort. Okay, so produces pulmonary vasodilation. It redistributes the blood flow, maximizes gas exchange, improves that VQ mismatch. That's associated with hypoxic respiratory failure or PPHN, sepsis, pneumonia, whatever. Always going to start at 20. We're also going to get a met hemoglobin on these kids. I believe it's every other day. I'm not exactly sure. It's just we need a baseline met hemoglobin, and then every other day. If your met hemoglobin gets too high, oxygen cannot bond to the red blood cells, and that's a problem also because we still want the oxygen to be able to get where it needs to go. Just a quick kind of some pictures of, you know, why are we going to use nitric and what does all this mean with PPHN and the blood mixing and all the things. This is a little slide that the nitric people put out. You know, maybe you are in rural Nebraska and you put a term kid on the vent. Oh, now we're on 40%. Okay, we can give surfactant. Let's do that. Now we're on 50%. We might need to be calling, you know, the transport team. We need to get this kid out of here. We're just going, we gave surfactant, it did nothing. We're up to 60%. Maybe transport team, came, or at some point somebody has decided, yes, we think you have pulmonary hypertension. We got to start that nitric ASAP. If you don't, this kid is going to end up on ECMO. Nitric is the only thing, getting those pulmonary pressures down is the only thing that is going to get this kid to ventilate. Again, this is what normal anatomy, blood flow after a baby is born looks like. And this is what you have with severe PPHN. You want blue and red blood, and here all we have is blue and purple. So nothing is oxygenated. Same thing here, persistent fetal circulation. In the womb, our pulmonary pressures are very, very high because we don't need to use our lungs in the womb. When you take those first few breaths and all the valves and all the things open and close like they're supposed to, your pulmonary pressure should go down. When they don't go down and when you have persistent pulmonary hypertension, that's when you need nitric. What does the nitric look like? This is what the screen looks like. Nitric of 20, we're going to read our FiO2 off of the nitric machine, not off of whatever ventilator you're on. The machine does auto-calibrate 1 time a day. It will look different during auto-calibration, but the nitric delivery is not interrupted. If you have to bag your patient, talk to your RT about how to do that. It is a little bit different than pulling that ambu bag off the wall. We want to bag with nitric if we have to bag that patient. So you do have to turn this little knob to get the flow going prior to bagging. So if you do have to bag your patient, just call your RT and talk to them about that if it's the first time you've ever had nitric. Again, we always want that FiO2 to be down first, and we want our PaO2 to be within normal limits, and then we're going to wean in increments of 5 until we get to 5, and then we'll wean in increments of 1 until we DC. So we'll go 20, 15, 10, 5, 4, 3, 2, 1. We're done. That's it. Thank you guys so much. Please, please, please grab any of us if you have questions. I need you all to know that as an RT, we take multiple classes on the different modes of ventilation and the different ventilators. I don't even remember how many classes. It's so many. And so we're trying to give this to you guys in a very condensed version. We don't expect you to know all the things and have everything memorized. But if you have questions, please just reach out. Thanks, guys.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.